Let's start. This is our seminar series, our Jameel Clinic seminar series, our weekly talks every Wednesday, 4 to 5. We're going to make sure that we have everybody on board as I let you speak. No need large introductions. We're going to have Pete Szolovits, one of our pioneers in technology and healthcare. And I think Amar Gupta will be also in the call or in the talk. They've been doing this work together. I'm going to try to corral some people, and I let you run the show. Please, the stage is yours, Peter and Amar.
All right, thank you. So I drew the short straw, so I'm giving the presentation today. But Amar and Yeju, who's also on the call, did a wonderful job of helping me prepare for it and provided some of the material for the presentation. So what I want to talk about is an important problem that comes up particularly as we're looking at it in this project in telehealth environments, because it's almost invariable that some of the data that you would like to have in order to make intelligent decisions is missing or is contradictory. You get multiple channels of data and they disagree with each other. And so what I want to do today is really review a bit of the background on how people go about dealing with these problems, and then tell you about some of the experiments that we're doing. And then near the end, I'll also introduce some data from a related project that I've been working on for a longer time than this one, which has to do with a similar problem of trying to impute data from other data that you have. And the funny title here, guessing what you almost know, is that a lot of times, if you look at a doctor dealing with these sort of inconsistent or missing data, they can actually make a pretty good guess about what that data ought to be, because from their general understanding of the case and from looking at the other variables that have been measured and at the trend lines of what's happening in their data, they can make an educated guess about what the value ought to be for some variable that is either in conflict or is missing. So, oops, be nice if I could change slides. Okay, so what's healthcare data? Well, it's big data. There are data that come from electronic health records, laboratory tests, pharmacy, hospital billing records, intensive care real-time measurements of high frequency data. There are now more and more data from wearable devices that measure data. You know, I have an Apple Watch that periodically figures out what my heart rate is and records it. There's also genetic data, but typically you don't encounter that in a telemedicine setting, at least not yet today. And then the important thing to think about for looking at the various techniques that we have for dealing with this missing data or contradictory data is what kind of missingness are we talking about? So typically people talk about missing completely at random, which means that something is simply not present in the data, but doesn't correlate with any of the other data that is present or with the outcomes that you're interested in. So it's like somebody took your data set and shot a shotgun blast at it and knocked out some of the data, but where the shotgun pellets hit had nothing to do with any of what's in the data. Missing at random, which sounds like missing completely at random, but is different, is actually means that the data is not missing at random, but it's missing in such a way that any of the non-randomness in it can be accounted for by other variables that you've measured and that you've recorded. So for an example of this might be, for example, let's say you're doing a survey and you ask people to answer questions by emailing them. And maybe you know from history that men are less likely to respond to such a survey than women. So in that case, you're going to have data that's not missing at random, but the fact that you know whether a respondent was a man or a woman means that you can account completely for that effect, if that's in fact the only one. And then missing not at random is all the other cases. There's this nice review of computational health informatics in the big data age, and they talk about the usual stories on volume, variety, velocity, and veracity in data. And they have this nice graph showing that we're now by 2020 up to whatever, half of whatever the next thing is after zettabytes, yottabytes or something. So there's just an incredible amount of data that's being accumulated. And of course, this means that there's a lot of opportunity to do studies based on those data and to try to learn something useful about medicine. Now, some of the challenges, especially in a telehealth environment, are that data come in very different formats. So for example, if you're dealing with different institutions, they haven't done a very good job of standardizing on standard ways of representing or even capturing the data. You have multivariate time series data, except the time series are not always acquired simultaneously. So you don't have the same, all of the measurements of quantities that you're interested in at the same time. The time series are not at regular intervals. So for example, if you look at the history of the serum potassium measurements that have been done on me as an individual, they're not done at regular intervals. They're done whenever some doctor thinks that that might be an interesting fact to discover. There are large gaps in the data for various reasons, and I'll talk about some of those a little bit later. There's conflicting information due to device differences, artifacts, changes over time, unknown factors. One of my favorites was I was working with a data set about 2 years ago where the data were all recorded in local time. And so in the fall, when we go from daylight savings time to standard time, there are 2 data series for the time between 2 a.m. and 3 a.m. on the day when time changes. So, that's a nice example where you get data that, of course, don't agree with each other because they're actually about different time measurements, but if you don't know that, you can get very confused. And in fact, we were never able to figure out which data series was from the daylight savings time and which was from the standard time, because there was nothing recorded that would let you know that. The other thing that I think is important, which I don't have any great insight into, is that the best ways to deal with missingness and with conflict really depend on what problem you're trying to solve. And yet we're treating it here and in this talk more or less as a sort of fixed problem that can be addressed for a variety of different applications. And I'm hoping that that's true, but it may not be. This is just some examples. On the right here is an electrocardiogram time series, and you just see that there are cycles that don't exist in the data. And this may be because a sensor failed or dropped off the patient, or there was a glitch in the recording equipment, or God knows what, but things like that happen all the time. This is from, Yuan was one of my former students, now a professor at Northwestern, And we're doing a project that I'll talk about a little bit later. But one of the interesting things is that starting with 7 million test results, if you want data that is relatively complete, you very quickly whittle it down until you have roughly half that amount of data. And in fact, it can get much worse, as I'll show you in this example, where these guys were doing a study where they needed to study patients who were on antidepressants and who were also taking an antihistamine, and they wanted to see whether there was an interaction between those. So they had relatively small data sets, 264 here, 2,200 here. There were only 44 that overlapped. And if you insist that you need data for at least a day during, before, and after the overlap time, you wind up with 4 cases. And obviously that's not very helpful because it's hard to build a machine learning model based on 4 cases. The other thing that's interesting is this was another study looking at the MIMIC-3 data set. And what they found was that if you look at the rate at which data is missing and the correlation of that missingness with mortality, this was a mortality prediction problem, it's relatively high. I mean, a 0.3 correlation is high enough that this really matters. And so you scratch your head and you say, well, if I had complete data, would my model differ significantly from what I have in these missing data? So this is an example of missingness that's not either completely at random or at random, because it does correlate in perhaps unexplainable ways with data that matter in the analysis. Data can be missing for other reasons. The big one is data privacy. So a lot of times, people can choose not to share their data. I'm doing a project now with UK Biobank, and every, I think, 3 or 6 months, they send out a spreadsheet that says the following patients have withdrawn from the study and you are no longer allowed to use their data. Please delete them. Okay, so this happens. There are shareability restrictions, both privacy-oriented ones, but also just proprietary data, and real-time sharing almost doesn't exist nowadays. It's very difficult to get real-time data shared across institutions. Okay, well, what is it that we're trying to do with this data? So the primary approaches to mining healthcare data are looking for associations or causality, building predictive models that are usually regression models. So you're trying to predict what will happen at some point in the future based on data that you've collected up till now. There are also classification models and anomaly detection models that make some discrete prediction. We're also interested in identifying clusters of patients who are similar in some interesting way. And then we're interested in doing feature selection. And as I mentioned a moment ago, depending on the analytics that are used later, the most appropriate method for filling in the missing data changes. And of course, having missing data and just getting rid of cases that have missing data can lead to biases or inaccuracies in the model, misrepresentation of certain categories, and too few data points for certain subsets of the data that make it very difficult to reach any sort of conclusions. By the way, I'll share my slides later, and I've tried to put in citations to the various papers that discuss these topics, and of course, much greater length than what I can do in a short talk. So, consequences of incomplete data. Well, it turns out if data is missing completely at random, you're in pretty good shape, because the missingness of the data has nothing to do with the content of the data. And so you have less power, but you don't introduce biases. On the other hand, if you have data that's missing not at random, then depending on what's missing, you have the opportunity and the risk of introducing various biases. So if your outcome data are missing not at random, then you may wind up with biased linear models. Although, at least according to this analysis, logistic models remain unbiased. And then exposure and possible confounders, if you're missing both outcomes and confounders, and if you're missing outcomes and exposure and possibly confounders, then everything can be biased, because that missingness may overemphasize certain cases and underemphasize others that will mislead your learning model to make incorrect predictions. I find this diagram sort of useful. So the typical thing, especially for time series data, is that you have a bunch of variables, variable 1 through m, and time points t1 through tn, which, by the way, are not necessarily regularly laid out. It may be that the delta between these is quite different. So if this is your situation and you're missing the data elements that are in red here, there are two things you can do. One is you can use the time series itself to do either like forecasting or interpolation or other kinds of extrapolation in order to use that time series as a way of giving you a guess at what intermediate points are likely to be. So for example, we know that in medicine, some things change very quickly. If I am measuring your heart rate at 1 p.m. and I measure your heart rate at 3 p.m., from those data, I'm very much unable to impute what your heart rate would have been at 2 p.m. because we know that heart rate varies. If I just say boo to all of you, your heart rate probably just went up by a couple of beats per minute. And that's not something that you can interpolate. On the other hand, if you look at something like what stage of tumor are you at? If you're developing cancer, that doesn't change very often. Or if I look at what's your hemoglobin A1C, because I'm worried whether you're a type 2 diabetic, that doesn't change very often either. And so I can do that sort of interpolation or extrapolation pretty safely. But the other thing I can do is that I can exploit the covariance structure among these different variables. And so I know that because there are, in fact, correlations between these variables, I can build a model that predicts what the value of one variable is from the values of other variables measured at either the same time or approximately the same time. So here are some of the imputation approaches that people have used. The simplest one is mean imputation. You take a population mean of that variable and you say, well, that's what I'm going to use for any values that are missing. And that works in some cases. Of course, it's a pretty gross approximation. Another one that's used quite a lot is forward and backward filling. You just say, well, whatever value I had for a variable, I'm going to replicate into successive time points when that variable is actually missing. Or backward, I can do it in reverse. Now, more interesting are multiple imputation and mice, which are two techniques I'll talk about in a minute. And then you can also use things like k-nearest neighbor, class center, and other nearest neighbor-based methods that say, well, if I can cluster my data in some way, then I can say whichever cluster you belong to, I'm going to use the class center or the mean value of a variable that's missing for you from that cluster. So it's a bit like mean imputation, except that it's more sophisticated because I can restrict it to clustering. Now, if you're dealing with both static and temporal mixed data, then there are various neural network methods that can be applied. One appealing one is recurrent neural networks and things like LSTMs that allow you to create essentially an embedding of an entire network of an entire series of data, and from that learn a model that will impute missing elements relatively accurately. I'll talk a little bit about 3D mice, which was a technique that we developed. And then there are, of course, missing forest methods, which is sort of a random forest-based method that does a similar thing, Bayesian networks, matrix factorization, etc. And then there are data augmentation methods like multi-layer perceptrons and GANs. And the technical issues that all these things have to face are dealing with high degrees of missingness in the data and how much parameter tuning is needed, how much accuracy is needed, and then also practically speaking, if you're dealing with a very large data set, then compute time also becomes important in the choice of techniques. So the methods that we're looking at in this project are Bayesian networks, mice and 3D mice, various recurrent neural network techniques, and adversarial network generation, generative adversarial networks. So in Bayesian networks, if you assume that data are missing at random or completely at random, then you can learn a Bayesian network that represents the relationships among those variables. So this is more for static data, although there is a dynamic version of Bayesian networks that allows you to deal with time series as well, multiple time series. And this was just a survey of the kinds of data that you're trying to learn from, and then various packages that exist in R and Python and various other languages that allow you to do learning of Bayesian networks. And of course, if you learn such a network, then the Bayesian inference allows you to say, hey, if I know the values of C, B, and E, then I can impute the values or the most likely values of other variables. And so this allows you to do that covariance-based imputation in a relatively sophisticated manner. Another technique that's very common in the statistical literature is called MICE. It's multiple imputation from chained equations. And it assumes that the data are missing at random given the variables that are used in the imputation procedure. In other words, the imputation, the data from which you're imputing are well enough known that you can treat the missing variables as depending only on those and nothing else. And so MICE builds a set of regression models, one for each variable with missing data that are conditioned on the other variables, and uses that to fill in the missing values. There are, of course, difficulties with these. You can imagine that like one data set I'm working with right now has about 56,000 variables, all of which are sometimes missing. So building 56,000 imputation models is somewhat daunting and of course computationally difficult. MICE doesn't have a very good set of theoretical guarantees either, and because these multiple independently calculated conditional distributions may be inconsistent with the correct joint distribution. And so you're not guaranteed that you're getting correct answers. It doesn't incorporate some of the ideas I mentioned before, for example, clustering to deal with similar cases similarly. And it's also true that an alternative, if you have nicely multinomial normally distributed variables, is to use a multivariate normal and just fill in data from that normal distribution. And of course, mice doesn't deal with time series. So the work we did a few years ago was to take mice and combine it with Gaussian processes as a way of trying to integrate the covariance data that we get from mice imputation, and to take the estimate of the correct value and an estimate of the uncertainty for each variable that we get from a Gaussian process approach, applied to each variable independently. And then we essentially just took the mean of those. Recently, we've done an analysis of where 3D mice, so this joint technique, actually outperforms most of the time all of its components. So if you look at the, I think these are RMS deviations from the actual value, and 3D mice does a better job than either mean imputation, which is the worst, or mice, or the Gaussian process by itself in most of these analytes, except for hematocrit and hemoglobin. And if you look at the covariance structure, you find that there are meaningful relationships here. So for example, you find that hemoglobin, hematocrit, and the prior hemoglobin and the prior hematocrit are strongly correlated with each other. And so it's sensible to say that you can expect mice to do a good job of that, imputation. Another approach, which has some similarities to the Gaussian process idea, is to use some sort of recursive neural network. And there are a number of different approaches that people have taken to this. The first of these references is actually from David's group, also from a few years ago. And the idea is that you represent the time series as just a series of data with missing values incorporated in them. In this case, we assume that there are two variables in the vector x, some of which are missing. S is the timestamps of when these measurements were made. M is a mask that tells you whether a variable is present or not in the data. And then delta is a time series of the deltas in time between these successive time steps. And you can use an exponentially declining parameter that says that the closer a missing value is to previously measured values, the more influential that is. And then you can build a sort of standard recursive neural network model that takes these different, the x's, the missingness, and the time deltas into account, and builds a recurrent neural network. And from the last stage of that, you then have a prediction layer that predicts the outcome. And so you can use a method like that. And as I say, there are many variations that have been developed on the same idea, but the fundamental idea is what's represented in this approach. The fourth approach we're looking at is really not a data imputation approach, but a data augmentation approach that says, well, one of the big problems with missing data is that you don't have enough data to build good models. And so one way to deal with this is to create fake data. And if the fake data is close enough to being real data, then you can actually use the fake data to learn from. I was very surprised. I had a doctoral student about 15 years ago, who's now a professor at Vanderbilt, who did an unbelievably crude version of this as part of his PhD thesis. He took an insurance data set from Harvard's self-insurance data, and he just calculated the covariance matrix of this data set. And then from that covariance matrix, he sampled, according to its probabilities, a large data set. And when he ran the analyses that he had run on the original data, he got essentially the same results. So that wasn't totally surprising, because the covariance matrix gives you quite a bit of information. But then he did the next step, which was to say, if we take this relatively high dimensional data set and pretend that it's a single multivariate distribution, and then simply characterize the means, the standard deviations, the skews, and the kurtosis of all these distributions, and use that to sample from, and then use that sample to redo the same analysis. What he discovered is that the effectiveness of the analysis was almost as good as from using the real data. I think he paid something like a 1% loss of accuracy in the analyses that he was doing. So to me, this was actually quite an interesting surprise. And I don't know exactly what it tells you, but it does tell you that augmenting data, he was doing it for privacy preservation, but augmenting data gives you similar opportunities. So this is just a schematic of a typical GAN, where you have a random number generator that generates data, and then you compare it to the real data with a discriminator. The discriminator tries to determine whether a sample is real or fake, and then that gets fed back to the generator. So the generator is trying to generate data that will fool the discriminator, and the discriminator is trying to learn how to tell generated data from real data. And these guys interact with each other to do a better and better job, until eventually this generator is able to generate data that looks like real data, and then you can use it in this data augmentation method. And then you can use different evaluation metrics, root mean squared deviation, standard error, mean error, etc. And I return to this point, which is that often what you're really interested in is, like in the example I showed you with Mimic, I don't know whether a 0.25 root mean squared error is much worse than a 0.23 root mean squared error. And what I'm really interested in is what's the effect of those errors on the real problem that I'm trying to solve, which is perhaps classification or anomaly detection. And that's where I really want to do an analysis of, to see what the effect is. So the research that we're currently pursuing in this project is we've selected 4 different approaches: 3D mice, Bayesian networks, recurrent neural networks, and GANs. And then we're looking at 3 different use cases. One is predicting the intensive care readmission data, or readmission rate. One is anomaly detection from electrocardiogram and pulse oximeter data. And one is continuous blood pressure prediction based on wearable data from things that you wear on your wrist or your finger. We're using the mice package from R and the BNLearn package and TensorFlow implementations for these. And for the ICU readmission data, we're using MIMIC3 data for this atrial fibrillation detection problem. We're looking at PhysioNet challenge data from 2017. And we're using a human activity recognition database and PhysioNet wearable data plus other data for using the wearables prediction problem. So what we're hoping to get out of this is focusing on remote patient monitoring, which is the context that motivated this project. What we want to know is, based on the analyses that we do of these use cases, can we tell what are the most suitable methods of data imputation and data correction for remote patient monitoring? And then can we deal with this in real-time data, which we don't have yet. We have pseudo real-time data, which was real-time data at one point, but is now recorded and static. And then we're also interested in exploring federated imputation learning methods. But some of the issues there are the amount of data traffic and adaptation to new data. I think I'll skip over this because I've said it conceptually, but you can look in the slides if you're interested. So the bullet points here are the missing data. And this is just speculations about what imputation methods might be best for these different scenarios of missingness. So for example, we think that if you're missing data in one time series, then things like Bayesian network or mice imputation from others is very helpful. This is more a censoring problem than a missing data problem, but you can still imagine using RNN type methods to generate missing data there. And then in frequently sampled time series like ECG signals, we have various approaches that we're pursuing. And there are also bidirectional RNNs, which are the fancy modern version of forward and backward filling data. And then Bayesian networks also help to allow one to use both the time series data and values from other variables, so the covariate structure. We've even looked a little bit at CNN-based methods, although that seems like an odd fit to this problem. But just like in signal processing, people have found that some of the methods applied for, developed for image analysis actually work pretty well for data analysis of more one-dimensional signals. So what we're hoping for is to compare different methods' suitability for usage in remote patient monitoring in terms of these various characteristics. And based on that, we hope to provide guidance on choice of analysis approaches when data are incomplete, and then perhaps to automate that choice process so you could build a kind of meta learner that figures out what is the best imputation approach to use. I wanted to finish by talking a little bit about a couple of projects that are not part officially of this JClinic supported project, but I think are related and interesting. So this is work we did a few years ago and got me started in this area. We met a group of clinical pathologists from Mass General who observed that there was a fairly expensive lab test called Serum Ferritin. It costs about $500, or at least at that time, it cost about $500 to do one of these tests. And that's pretty expensive on the scale of laboratory testing. So they said, well, this is really a measure of iron stores. And there are a lot of routine tests, cheap tests that are done as part of panels that are also correlated with iron stores. And typically, doctors don't really need to know the exact ferritin level. They only need to know whether it's abnormal. So in this case, the question was, could we build a model that used a lot of their data that would make a good prediction of this? And the answer was yes. So we were particularly interested in low serum ferritin values, and we were able to build a model with an AUC of 0.97, which is pretty good. And the way we did it was relatively simple. We said, well, we're going to use predictor variables, which are all the other, so this is the covariance structure. It's all the other variables that are measured. And if there are missing values in those predictors, we're just going to do mean imputation. So initially we started with mean imputation. Later we got fancier. And then the ferritin value can be predicted as a regression to get a numerical value, or as a classification problem to predict normal or abnormal. And as I say, at the second one, we were doing pretty well. Now, one reason for that is because most ferritin values are not near the decision boundary. And for those, it's relatively easy to tell that the value is normal or is abnormal. And so the only ones where it's difficult are where you're near the boundary. Now, the other thing that the doctors we work with pointed out is that the value of this is not only to guess a serum ferritin value when you haven't measured it, but to do the prediction even on quantities that you have measured. And if the prediction is very different from the value that you measured, that says you should pay attention. So what we found is that out of 1,500 cases, there were 26 in which there was an order of magnitude discrepancy between the measured serum ferritin and the predicted one from our model. And so we went back, picked the 4 most discrepant cases and had the doctors dig into that. And what they discovered was that the predicted ferritin was actually a better indicator of iron deficiency than the much higher measured value. Now you scratch your head and go, how could that happen? This is just the correlations. And the answer is that in one case, a patient actually had iron deficiency, which was not identified, but the ferritin is sensitive to inflammations. And so this patient had some systemic inflammation that drove up his ferritin value, but in fact, the predicted value, which was lower by an order of magnitude, was a better indicator of his true iron status. And similarly, so this was somebody who actually had iron deficiency, was receiving intravenous iron. And so as a result, their ferritin was high, but their iron stores were in fact low. So if you look at the data, it's kind of interesting that doing this prediction and comparing it to the actual measured value is a useful indication. And then the last thing I just want to mention is we're currently doing a project with a ton of data from both Northwestern and Mass General, where we're looking at every patient who has gotten a complete blood count and trying to figure out whether they have a ferritin test that is ordered simultaneously or is going to be ordered in the next 30 days. And the predictors are their age, gender, the CBC results, and other labs, certain other labs within the last 2 years, but excluding the last 3 months. So we have sort of a washout period to try to make sure that we're not predicting something that is already true. And the target was ferritin test ordered. We have an 80-10-10 split. We're using random forest as the best method. And this is a kind of wisdom of the crowd approach. And the thing that always makes me nervous about these is the difference between should this test be ordered versus is this test typically ordered in that case. And here, if you're making a prediction that says, well, if it was typically ordered in this case, then it should have been ordered. Then you're building a decision support system that says the crowd is wise, and therefore it's appropriate to make recommendations based on what other people have done. And we think that that's true, but I'm nervous. So the model performance is pretty good. This is a calibration curve of the predicted probability of test ordering and the fraction of times that the test was actually ordered. And you see that for, this is the perfect correlation line, and we're pretty close to that. So we're getting fairly decent results. Here there's less data, and so you can see that the uncertainty is much higher. And then this is a feature importance report on what features that we look at are most important in helping us make this decision about whether a ferritin test ought to be ordered. The other thing that's interesting is if you look at the relationship between the predicted probability of ferritin and in those cases where the test was actually done, what was the value of the test? There's a pretty good correlation. So it tells you that if the model that predicts whether you should order ferritin says yes, then you're likely to have a high ferritin value. I'm sorry, a low ferritin value. This is the percentage of cases in which it's low. So that means we are capturing some medical reality in this method. Now, I leave you with the last thought. David's seen these before because I use these, I use the bottom example in a class we teach together. This I discovered just last week. I'm using a large utilization insurance data set, and I'm looking at this data set and I see that the distribution of years of birth among cases of inflammatory bowel disease looks like this. And I go, whoa, what the hell, right? How come there are, about maybe 9 or 10 times as many people born in 1929 as there are born in 1928 or born in 1930? Any guesses? Well, I'll give you my interpretation. So this data was collected in 2019. And in 2019, the people who were born in 1929 were 90 years old. Now, if you remember the HIPAA regulations on privacy protection, it says all ages over 89 and all elements of dates indicative of such age may be aggregated into a single category of age 90 or older. And so apparently what happened here, I think, is that some of the data they collected, most of the data they collected, obeyed this rule. Some of it did not. And so there are a few patients who are actually older than 90 in the database by their birth year. Or it's possible that these patients were collected earlier and at the time they weren't yet 90, and that's why we have them. But it means that this giant spike should actually be distributed over in this part of the graph. The other mystery, this is heart rates from MIMIC. So you look at this and you go, wouldn't you expect heart rates to be essentially normally distributed? But this is obviously a big bimodal distribution. So what what the heck is going on here? Again, I'm happy to entertain a guest if somebody wants to offer one.
I think Randy's raising his hand.
I'm sorry, say again?
Randy wants to say something.
Are they being measured in two very different circumstances?
Not really, no.
Figured, somebody had just run up the stairs versus somebody who's sitting around in the waiting room.
Well, that would explain it, but there are a lot of people who would have had to have run up the stairs. And that also wouldn't explain why there's a dip in the middle. Well, here's the real answer. If you look at the distribution of heart rates versus ages in the entire mimic 3 population, what you discover is that mimic actually includes a bunch of neonates. So these are people who are no older than about 3 months. And neonates have very high heart rates. And so these are the babies. Then mimic includes people from about teenage up to age 90. And here there's a slight decreasing trend, which is what you'd expect. People's heart rates slow down a little bit as they get older. And then there are a bunch of people who are 300 years old. Why are there 300-year-old people in this database? Well, the Beth Israel takes really good care of its patients and they live to be 300. No, actually what happens is that their way of dealing with this HIPAA regulation is that once you reach age 90, you're declared to be 300 years old. And so that's just a coding artifact that is their way of dealing with the HIPAA regulation. Notice HIPAA doesn't say you have to declare these people to be 90, which is what they did here, but just something else. And so these guys chose 300 or higher as being an indication of that. So those problems are difficult to deal with in any sort of imputation method, because you really have to understand something fairly deep about where the data came from in order to try to understand why those things happen. So with my favorite elephant, this represents the end of my talk. And I'd be happy to answer any questions if you have them.
Thank you so much, Peter. That was fantastic. Really, really inspiring, and some of these thoughts that over the years accumulated on this experience. But let's see if we have a couple of minutes, 3 minutes for questions. I'm sure that we may have some.
Randy.
Not really a question so much as a suggestion. You hinted at this on one of your slides, but I think even a brief tutorial article on the different methods and their appropriate uses would be a fine public service, and a lot of people would be interested.
So there have been periodically such review papers, and I actually don't know whether the most recent ones are up to date enough that I would want to compete with them. But yeah, that's a good suggestion. Given infinite time, this would be a good paper to write.
Or given one more graduate student.
Is that a hint to Ignacio to increase our funding?
That's it. That's what it sounds. Yeah. Maybe we have time for a last question. Amar, any reaction? You've been part of this work as well.
No, I think it's covered everything, including things which were done before me. The challenge, of course, which I want to mention is getting proper data for all this work. It's always been a challenge getting it. And since we didn't find much, in some cases, we have used the data from Mimic. We should, again, think of ways, which I've talked with you, Ignacio, also. If we can get any other data sets, we'd like to use them. And then we can have a common pool of data that we can use for different projects and see how the different methods perform on the different sets of data. That's what would be useful.
Excellent.
That's the same approach which you use today in a paper which is highlighted in MIT News today, is the one which we did in the financial industry, where we were able to get data in the public domain. So we'd like to do the same thing here if it's possible. That would be my suggestion and request.
Okay. David, final one for you.
I sent an email to you, Pete, but I think it would be interesting to try to characterize treatment variation on the ferritin example you mentioned, right? So it's not obvious if wisdom of the crowd is a good idea here, but part of the process of trying to answer that question might be to understand why is it that people are making some ordering decisions versus others. So if you could get provider information, for example, or an additional patient context, you might be able to try to characterize both what institutions and which providers are making decisions one way versus another, and that could be insightful in itself.
Yeah, so one of the limitations we have in that study is the people we're working with. Anand Diga is the director of the clinical labs at Mass General. And so he has excellent access to the clinical labs data, but not as easy access to any of the other data. So even a place like MGH, which is pretty advanced in its IT competence, it's much harder to get data out of RPDR, for example, than it is to get data out of the lab information system, because I happen to have a collegial relationship with the guy who runs one, but not the other.
Excellent. So thank you very much, everyone. I think we're now on time. If there's only any other question, thank you again, and see you next week, the same time. I appreciate, Peter, your help today. Thank you.
Great. Thank you for your attention.
Thank you. Bye-bye.